Healthcare and senior care is fraught with problems and challenges, but we're also seeing some amazing new clinical treatments and resources. This show will help illuminate and uncover the good, bad, the ugly in order to equip patients, families, and other healthcare providers. Welcome to Senior Care Confidential. Hello and welcome to another edition of Senior Care Confidential. I am here with my new friend, Dr. Jenna Wishnew and Marina Lakhmanchuk. We figured that today would be an opportune time to talk about wounds. There's a lot of wound stuff going on. There's a recent statistic that says that 57% of clinicians since the coronavirus pandemic have seen an increase in severity in wounds. I know we see it in our practice. And so we felt like this would be a great time to make new friends and to have a great discussion with Marina and Dr. Wishnew on wounds. So Dr. Wishnew, welcome to the show.
Thank you so much. I'm so happy to be here. I love sharing knowledge.
Can you give me a brief background of the audience, a brief background on how you came into wound care practice?
Sure, absolutely. So I did my residency at Texas Tech. It was the largest burn center within 500 miles. And when I finished, I thought, I'll just concentrate on general surgery. No wounds for me. But as I encountered wounds more and more, I realized that I had to put that knowledge to use. I couldn't keep it to myself, mostly because I'm bossy, but I really wanted to help improve patients' wound care with all the things that I learned.
Awesome. And then Marina, it's the second time on here with you.
Yes.
A brief background on you as well.
Yes.
You are my favorite type of clinician, no offense, as a physical therapist. Yeah.
So I think, naturally with the lymphedema aspect, love lymphedema. Lymphedema and wound care, they go hand in hand. And so, in that space, this is just what you have to know. You can't do lymphedema without wound care.
Absolutely.
So.
Yeah. All right. So one of my favorite topics is anything that refutes like common practice or things that our grandmothers used to do. So what are some common misconceptions that you see in your practice for wounds?
So one thing that drives me crazy is hydrogen peroxide. It is a great product to clean the wound one time.
Yeah.
After that, it kills everything. It kills bacteria. It kills fungus, it kills healthy cells. So when patients continue to use it and then wonder why their wound isn't healing, that's why. Because the hydrogen peroxide is killing everything. Same with alcohol. Great for killing everything, including the bacteria at the beginning. So I would say if you have a wound that you got on a dirty bike spoke or in a lake, clean it with hydrogen peroxide. Soap and water is better, but hydrogen peroxide, fine. After that, soap and water, keep it clean.
That's it, because it's too caustic to the actual good tissue.
Absolutely, yeah. It lyses all of the cells, good, bad, and indifferent.
Okay, and we were talking about a couple things. One on the scabs, like before the show, we were talking about scabs, which I'm such a moron. I have a very different
everybody
perspective
thinks, let it dry out, let it scab up, that's the way.
That's your Band-Aid. It's like the natural
curtain. The new skin will come in.
Telling the body, I spit on all of your hard work. Because your body's done so good to bring all of these healthy healing cells to the wound surface. And what do? You just let them dry up like the desert? No, don't do that. Wounds are like Goldilocks.
Okay.
They can't be too wet, but they also can't be too dry. If they're too wet, all of the healing cells come to the wound surface and they just get swept away with moisture.
And they're too wet if the bandage is too wet at the end of the day or whatever. Or if they've got, you mentioned like that white ring.
Yeah, so the wounds get a white ring around it. Or if it looks like you just got out of a bathtub.
Okay. Yeah. So that's too wet.
You'll see a color change different. So it'll be either just much more whiter than the other surrounding skin and more white than the pink wound bed.
So too wet obviously is bad.
Yeah. And another way you know is if you're having to change your dressing more than once a day.
Yeah.
Because it's saturated.
Okay, gotcha. That makes sense.
Getting on your clothes, that's too wet.
Okay.
By that same token, you don't want it to be too dry. If it's scabbing up, or if your dressing is sticking to it because it's too dry, then you're letting all of those healing cells that have made their way to the wound surface dry up and they can't do their job. And so the ideal thing is to clean it with soap and water, slap a good old Band-Aid on it, and your body will make its own enzymes to heal itself. So by keeping it occluded, so a Band-Aid ideally that is occlusive on 4 sides, silicone is the best bandage, so gentle, especially for older skin.
Okay.
They sell it at the CVS Walgreens type stores now. those are the best. That
Okay.
keeps it in. It keeps the good stuff in. It keeps the bad stuff out, and it keeps that moist wound environment.
So the
That's
goal
what
is
we
to
want.
never let it get to a scab. Is that what I'm hearing? Wow.
Yeah.
Okay. Interesting. Now, what if it becomes a scab? What do you do then? Do you pick it?
No. The fingernails are the
Coming
worst.
from the guy in the room. Yeah.
Yes. Do not pick your scabs. If anything, wash your hands, cleanse it with a nice clean gauze. If it comes off, it comes off. But by keeping it covered, your body will heal underneath the scab and eventually push it off.
Okay. Gotcha.
Because a lot of the Band-Aids will create just a slight amount of moisture that will cause that to kind of self-debride. So it'll be new skin underneath.
Got it. Okay. All right. And one of the other things that we see, and I know you see them too, because you work with older people too, is a lot of skin tears. What is some misconception on the skin tears?
Please don't use tape.
Oh,
Yeah. So
Yeah.
the funny thing about that is the body is giving you its own bandage.
okay.
Take the skin, put it back over the tear, and again, cover it up. The body will actually reseal that skin right back where it's supposed to be.
Okay. Okay.
If the skin is still moving a little, or if it's sticking to your bandage, a little Vaseline A&D ointment on it will keep that skin where it needs to be and not stuck to the bandage.
Oh, that's a great idea. Okay. What are some other misconceptions you guys run into?
Oh,
Blisters.
Oh, yeah.
Do
blisters. Okay.
not pop the blisters. Don't. What
Yeah.
did we used to do back in the day? You'd like,
Pin.
yeah, you do the pin with the alcohol, and then you just
You
let
light
it
it with
seep
the-
out, or you would light up. Yeah,
Yeah, light
so-
the pin with the lighter. That sterilizes it, of course. And then stick it in there.
and then
squeeze
stick it in there and let it squeeze
Yeah.
out. You're
So
laughing.
again, the body is giving you
I've
its
done it.
own.
yeah, exactly, exactly.
Like Neanderthal over here. Yeah.
Yeah, but the body's giving you its own bandage.
Yeah,
So the body
okay.
has put its little bandage beneath all that liquid on there. The problem becomes when that blister is too big.
Yeah.
And then you risk it being sheared off. Then go to your doctor and have them sterilely drain the fluid. And again, push that skin down.
yeah.
So use a bandage to push the skin
Yes.
down. Okay.
Use a bandage, but then also use some kind of compression to push that fluid back into that interstitial space and let the lymphatic system.
Yeah,
Okay.
your body
Fluid
will
away.
reabsorb it.
Yeah.
It
Nice.
doesn't have to come
Okay.
out through your pinhole.
Very good. In your practice, what are the main types of wounds that you guys see typically?
So I see a good variety.
Okay.
I see a lot of pressure ulcers because I do cover a hospital. Pressure ulcers are areas where the bones are prominent. So on the heels, on the elbows, a lot on the sacrum, which is your tailbone, and on your hip bones that you sit on, or on the sides if you lay on your sides,
Yep.
especially in people who are differently abled. So they're having to stay in the bed, in the chair, or have decreased feeling in their feet, either due to reduced blood flow or diabetes.
Yep.
So those are a huge percentage of the wounds. I also see a lot of diabetic wounds. It's really unfortunate, the rise in diabetes nowadays. And because of that, we're seeing a lot of diabetic wounds. And further than that, the wounds that people get that aren't quote unquote diabetic, which are typically foot wounds, the wounds that they get just in general, skin tear here or a pressure ulcer there, they're worse because the blood sugars being high at a baseline gives those bacteria a way to just multiply. They have all the fuel they need to multiply. And the high sugars paralyze your cells. They can't work in a situation of high sugar.
Right.
So because of that, they can't heal the wound. And so something small that heals very quickly ends up not being able to heal and needs help.
Festers. Yeah. So given that, and we deal with a lot of pressure ulcers, especially since we started seeing it a lot more throughout the pandemic. And a lot of that was because of we had rehab hospitals and skilled nursing, even like the major hospitals, they would have like the COVID wings, and they were very infrequently visited. A lot of times, like when in the midst of all this, patients who go from the hospital to like a skilled nursing facility or rehab, and they would spend like their first, whatever it was, like the days, the CDC kept changing. It was like 7 to 10 days, like on this COVID wing, where they were never really gotten out of bed. And so then they moved to the real rehab wing to rehab over there. And by this time we've already got, I swear it was like every other patient we're getting out of rehabs and hospitals back then had pressure ulcers. We're still seeing a good deal of those now. So like, I know in our practice, the pressure ulcer thing probably is the biggest thing that we see in terms of wounds. It also has probably something to do with the fact that we see an older patient, a little more frail. Going along with that, we were talking before the show about the importance of nutrition, and I know you do some education on that. What do you teach? Is a nutritional component? Let me put it this way. How important is a nutritional component? And is it different depending on the type of wound, or is it just general nutrition principles are applicable across the board?
So general nutrition principles are applicable across the board.
Okay.
So the healing of a wound, the scar, is made of collagen. Collagen is protein. So you need protein to heal. So a high protein diet is good in the general population, but even more so in someone who is healing a wound. Okay. So generally we recommend 80 grams of protein a day for the average person. More than that, 100 grams of protein at least for someone with a healing wounds. Because not only do you have to run your body, you have to then use more protein to heal the wounds on top of it.
Yeah, the resources.
Absolutely.
Yeah. Okay. And do you find I'm sure you do, but for folks who are not as compliant on the nutritional side, are the wounds are they getting worse? Are they just festering for longer? Are they like? Can you
They're
tell?
Stagnant.
Okay,
oh yes, yeah. I tell
you
people,
can tell when they're malnourished in terms of like the protein.
I can tell when they change their diet within a week. Yeah, within a week or two of them increasing their protein.
You see more proliferation of the healing tissue.
Yeah, the wounds will just zip.
Wow. Okay. Fascinating. Okay. And we were talking about when they see you in the wound care practice, like a lot of the stuff that you do is debridement. Yeah. What's the purpose of a debridement?
So the purpose of a debridement is multifactorial. One is over the course of a week, a wound accumulates debris, dead cells, both debris from the dressing and then also from the environment, bacteria, drainage, all of that makes an invisible film over the wound surface that can't be removed just by cleansing the wound alone.
And that happens even if it's been dressed.
Every
correct?
Wound, yes.
Okay.
Yeah. So beneath the dressing, this forms, and that does two things. One is it inhibits the wound underneath it from healing, but also it doesn't allow the products that we're putting on top to penetrate to get to the wound to heal it. And so once a week at least, only once a week, no more than that is what I mean to say, you need to remove that. And so the way to remove it is to numb the wound and physically, I don't want to say scrape, but we remove that sharp debridement with a scalpel or curette in order to remove that film and also make it bleed just a little bit. And what that does is it tricks the body. It tells the body, this is a brand new wound. Send all of your best wound cells to the wound surface. And so every week that wound gets reinvigorated. The body says, oh, it's a new wound. Oh, it's a new wound. And so continually we stimulate the body to heal that wound faster.
Gotcha. Okay. And then I know you and Dr. Wishnew work a lot together with patients with wounds with lymphedema.
We do.
What is that typically? Are those wounds, I would imagine those wounds aren't necessarily pressure wounds, but there may be some of those. Are they a different classification?
I think that those are going to be arterial and vascular in nature for the most part. And with the lymphedema, with all the fluid in the skin, it just creates that stretching, creating that blister. And that ends up popping because the patients put a little needle in it or scratch it. Right. And then we end up having wounds with lymphedema because they have a compromised immune system. Infections, they're more susceptible to that. And usually we immediately bring in wound care to help.
And the problem with swelling in a limb like that's having the blisters or cellulitis or whatever is what? I think you were telling me last time that it blows open the skin. Like there's no way for it to create the bridges because it's too stretched. Am I understanding that correctly?
The fluid sits in the interstitial space and that skin just gets so overstretched that it basically becomes, microporous. And so it creates, the fluid can't go up, so it's got to go out, and it creates those blisters. And
this goes back to what we were talking about before. A healthy wound bed can't be too wet or can't be too dry. And if we're constantly stretching the skin tissue to where it's more porous and the fluid is able to seep out, this is where you get more festering of the wounds, which is where lymphedema comes in. And it
self-perpetuates because the more you stretch, the bigger the wound is. The bigger the wound is, the more area there is to drain. The more it drains, the more it breaks down the skin.
Sure.
It makes a bigger wound. And so it perpetuates itself. And the funny thing is people respond when we ask to compress them like, no, you're going to put pressure on my wound. It's going to hurt.
Yeah.
But it's the opposite. By pushing the fluid out of that space, release, you push it higher where the lymphatics and the blood vessels do work to bring it back so you can get rid of it. It actually makes the wound smaller. It makes it drain less, and it makes it feel better.
And it helps the blood flow, and more blood flow heals wounds.
Okay.
Absolutely.
And I remember you telling me before on last time I had you on that the lymphatic drainage massage is actually very light because it's not deep tissue. So is the amount of pressure that you apply with that compression, is it similar? Like it's just a light amount of pressure, or is it harder? Like, is there more tension to it?
The pressure when we're applying lymphedema is probably around 30 to 50 millimeters of mercury.
Okay.
So your regular Coban, like 2 layer, is somewhere around 20 to 30. So it is a much larger amount.
Okay.
And we are helping stimulate that, blood flow to help create the pump system to move that fluid upward.
So is it uncomfortable if you have wounds that are already irritated? Is it uncomfortable to have those stockings on?
So sometimes people don't like the pressure of it, but then we could go slightly less intense for a few weeks to get some of that swelling down.
Gotcha.
And
just to make some progress.
I'm sure that Marina touched on it last week, but compression is additive. So you start with a very large leg, you apply compression, and that makes it smaller by the end of the day. And then you go to sleep, gravity doesn't push any more fluid in there. So the next day you start with your starting point is much smaller to put your compression on. And then by the end of that day, it's smaller. You
and
go
the
to
pooling
sleep.
is less.
Yeah. So each time you wear compression, it gets smaller and smaller.
Makes sense.
And so the amount of pressure on that skin
that you feel
is less.
Okay.
Yeah.
And so that's why it's so important that they wear the compression anytime they're upright, before their feet hit the floor in the morning, because as soon as gravity gets a hold of it, it's pushing that fluid into the legs and your starting point is bigger.
Right.
So they say, I was wearing compression socks, but they don't fit anymore. Then I know that they skipped a day or a week or a year because their starting point is now bigger. And once I explain that to them and they finally get it, which my patient just yesterday came in with his head down and I said, you wear compression this week and you're healed. And he said, I should have listened to you. And I said, this was 3 months of me telling you to just wear. And in 1 week we healed you.
Awesome.
That's all it takes is just be consistent and you'll get results.
It's an uncomfortable thing because I'm trying to draw back from my knowledge of the anatomy books, but Meissner's corpuscles, I believe those are the ones that are the pressure sensors. Is it, when they're talking about it being uncomfortable wear, is it those are the sensors that are triggering the brain to go, this is uncomfortable? But as the time goes on and you're wearing it more consistently, they get smaller, so there's less pressure, so it feels more comfortable?
I think if they're in the right compression, I really see these patients go online and they are like, I think I'm going to be a large. I'm a large in everything. And then they, pick the socks.
Yeah.
You have to decongest the limb before you put on go straight to socks and garments. And sometimes the patients want to skip that step. And that's where they're basically, putting on a sausage casing and it's super uncomfortable for them. But if they are wearing the right size, they usually are super comfortable with it and will be more compliant.
My best comparison is if we'll pretend Shaquille O'Neal and I are both a medium. His heel to knee distance is much different than mine, but we're both a medium around our calves. We'll pretend. I'm 5'3". Shaquille O'Neal is 7'3". Yeah. And so our mediums are going to be different. And so that's why getting them off of the rack at Amazon or the grocery store are not the same.
Sure.
Because when we order them for you, one, we've gotten you down to where that's your actual size versus if you buy an extra large, by the time we get done with you, you're no longer an extra large.
Hence the reason to work with a lymphedema specialist.
Oh, yeah. And that's why I like to go and market with Marina, because a lot of vascular doctors are like, oh yeah, we do lymphedema therapy. We wrap them. And it's not, it's multifactorial. It's wrapping sequentially week after week so that you're continuing to reduce the size of the wound. It's doing the pressure pumps to, again, stimulate those lymphatics, stimulate those veins to get rid of it. It's seeing a lymphedema therapist that can put you in a proper garment once you're done to maintain the success that you've had. So it's multifactorial. It's not just a one thing. It's not just throwing pumps or throwing wraps.
When you guys are working together with lymphedema and wound care, if there's a wound on the shin or wherever, you guys are doing the dressing and then applying the wraps, or are the wraps the dressing at that point?
Sometimes the wraps are the dressing, but most of the time not. Most of the time it's a collagen, an absorptive dressing, and then also compression. It's multifactorial.
It just depends on how much the patients are draining, whether we're going to do a throwaway wrap that ends up being part of the wound care but there's wraps have gotten so advanced, like the wound care, that they're able to provide the same 30 to 50 in a throwaway, cutaway use, which is really great.
Yeah, that's nice. When should somebody, so I see a primary care doctor, I've got a wound that's not healing. At what point do I go, I need to call Dr. Wishnew or another wound care specialist? Like, what's the triggering event for that?
Sure. So a lot of it has to do with your personal history, but also the history of the wound. Okay. So if you are someone who has a history of vascular issues, whether it's swelling or arterial insufficiency, or you have a history of diabetes or skin cancer, actually, then you need to consider seeking a wound care professional sooner. So after even a few weeks, if it's increasing in signs of infection, redness, drainage, smell, swelling, see a wound care professional sooner, because the smaller the wound is before it gets out of control is much easier to treat than when it gets out of control. Also, a wound becomes chronic after about 4 weeks, meaning it should have gone through all of the stages of healing in that time.
And scarred over by 4 weeks.
Yeah, for the most part after 4 weeks, unless you have those other conditions. Yeah. After about 4 weeks. So after that time, that means it's gone through all of the acute processes and it's become now a chronic wound. So a chronic wound means that it's stuck in the inflammatory stage. So the cells that the cells that you find in that wound are different than the healing cells of a healing wound, an acute wound. And so that's what a wound care specialist does, is they look at that wound, sees what it needs. Is the pressure okay? Is the infection okay? Is the nutrition, the blood vessels, the swelling, all of those things, is it absent from trauma? And so that's what they're evaluating. So I would give it a chance to heal, but if you already know that you have some condition that delays your wound healing, then that's when you would see a wound professional. But also if you have something exposed, bone, tendon, muscle. Oh, yeah. Sooner.
Okay. Because I know we work with some primary care doctors who will send over wound care orders. And it seems pretty regularly that we're pulling in the specialists for the wound care piece of it.
And that's another thing that I get questioned a lot. Why do I need a wound care specialist if I have a wound care nurse, home health?
Yeah.
And this is what I say. We work together. So the wound care specialist evaluates all of those things, the trauma, the blood flow, the infection, if anything's exposed, and the home health can carry it out.
Correct.
And a good home health, and this is how Marina and I bonded, is a good home health will say, something's changed.
Yep.
And they will identify if whatever order you've given, the wound provider's given, is not appropriate anymore, then they can come back. And that's why there should be an open line of communication between the two. Yep. And for instance, a patient I just saw this morning, I am so sad for, because they've been seeing their doctor. They've been seeing an infectious disease doctor for 6 weeks on IV antibiotics. And they got sent to me to treat this wound. It was just a little hypergranulation or a little piece of proud flesh, but nobody had bothered in the wound. They'd been seeing home health who'd been covering it. No one had ever bothered to stick a Q-tip in it.
Oh no.
And it tracked straight to the bone.
Yeah.
And the patient was going to finish antibiotics tomorrow. She was going to go back to Arkansas where she lives. And she had all these plans. And I had to break it to her that for 6 weeks, you've had bone exposed and no one put a Q-tip in it.
Oh, man.
Block test.
Yeah.
Wow.
I stick my finger in a Q-tip in anything that I can because you never know what's below there. That's what the importance of a wound doctor right there.
It's like an iceberg. You only see like what's on the top.
Oh, yeah.
Yeah.
And it's really hard to tell. You really have to look in there because it just may be a slither. And if the wound has a ton of slough in it, you don't really know.
Or sometimes it's pink. And the only way you know is because through the pink, you can stick a Q-tip.
Yeah.
So you touch a Q-tip in every single wound just to see if there's any breakthrough?
I measure everybody's depth.
Okay.
Whether I can see the bottom of it or not. And sometimes it's surface level. And so it's
It stops.
It stops, yeah.
Gotcha.
But it's the ones like this. And the one that I saw last week, same thing. Everyone said, oh, it's almost healed. Go see her to finish it up.
It's just a pinhole.
And yeah, it's into the joint. And nobody bothered to stick a Q-tip in it.
Wow.
Because it looked like surface level.
Yeah, I know we use wound care specialists a lot. We've actually worked with your practice quite a bit too. And so it's nice to have like having a one time a week look at the progress of the wound, and getting updated orders for the nurses in the field to work off of has been hugely helpful.
Yeah, and I love your practice.
Yeah.
I love working with y'all because you have experienced wound trained nurses.
Yeah.
But a lot of home healths don't. Their home health training is what they learned in nursing school, which is 1 hour lecture or whatever it was.
Yeah.
And that's not enough to recognize these things. And so seeing your wound practitioner, they can specialize the wound care specifically for your wound.
Yep.
So if it needs more moisture, they can add something in to absorb. If it needs something antibacterial, we can add something in. If it's ready for a healing dressing, we could add that in. And then we even have advanced modalities that we can use. Skin substitute grafts, fish skin, pig skin, amniotic membrane, shark cartilage.
Interesting.
Split thickness skin grafts. So I can take skin from your thigh and move it onto your wound if it's ready for that. Hyperbaric oxygen treatments. There are so many different advanced modalities that we can do if we're seeing you, and we can prepare you for that.
Sure.
Yeah.
And I think sometimes, what patients do for you guys is they go in and they clean the wound, they go shower, they do all the things. And so the wound doesn't present to you. They'll go and put on a fresh Band-Aid when they go see the doctor. And I just advise the patients, don't do that, because the physician really needs to see where the wound is actually at. Because sometimes you and
how much drainage
is happening, what the drainage looks like, because they want to do the best and they want to be presentable in front of the doctor. And sometimes that doesn't really
we need to see the ugly.
We need to see the ugly.
Yeah.
And that's why a good home health agency is just...
Yeah, I say it all the time.
Yeah.
It's like,
I take lots of pictures.
Even within this context, like there's one environment, for all the other environments in healthcare, hospitals, rehab, SNFs, there's one environment that's invisible to all the rest of them. Like even physician practices, it's the home. Like there's so many things we need to pick up on in the home. Like this is really where you see, are they being compliant with the nutrition stuff? Like we're opening cabinets. Like what does that look like?
Yeah.
So there was a recent statistic, I think for last year, actually, they say $97 billion of Medicare dollars were spent for wounds. And this is probably hard to parse. I just want to get like kind of your opinion. Is it because we're getting to, is it maybe not a neglect, a misunderstanding or misapplication of how to offload joints? Is it more like the chronic illness? Like we talked about systemic inflammation and it's causing vascular issues or diabetes issues, and that's what's causing wounds. Of the 97 billion, is a majority of that or half of that like preventable, or is this just? I don't know. You want to go with that?
Yeah, I don't know what the percentage is that's preventable, but it is a large percentage.
Because you see a lot in your practice.
I think a fair portion is non-compliance.
Okay.
But I think a fair portion is doctors trying not to put the burden on others. So primary care doctors trying not to have to refer to a wound care doctor, because it's nothing.
Oh,
and then I find that the patient has skin cancer. Yeah. Or I had a doctor that was just packing a wound for months, and the guy ended up having to have his whole leg amputated, because not even just portion, because they had so much bone infection at that point that his whole limb wasn't salvageable. And so they're just trying to, and I asked the doctor, I said, you have me, I'm just upstairs. Like, why did you wait so long? And he said, I thought I could handle it. I didn't want to burden you. It was just looked like nothing. And I understand that. And that's so kind,
sure.
But no, give it to me when it's really easy. And then I can heal it
faster.
Before it becomes really difficult.
Got it. Okay, interesting. What else should we know about wound care specialists?
So another common misconception is swimming or bathing with wounds, soaking wounds.
Oh, yeah, there you go.
Yeah, patients all the time, but it's summer. I want to go swimming. I'll just put a Band-Aid on it.
Mm-hmm.
Going swimming or bathing is like a soup of your own bacteria. Or if you're swimming in a pool of other people's bacteria, and you're just letting that bacteria just get into your wound and that bandage is holding it there.
Because what they should be aware of is that the skin is the largest organ in the body, and it's like the number one defense. It's like one giant shield, and once there's an opening to the shield, things will find their way into it.
Yeah, but also your bacteria is now in everybody else's. People go to the bathroom in the pool when you're sitting in your own bathtub.
You don't swim, do you?
I do.
She has her own private pool, I'm sure.
I never get out. I don't know what it is.
But it also changes the skin integrity because, when you sit in the water, your skin gets wrinkly and it gets that whiteness. So if you already have a wound with skin integrity issues around it, now you're just making it worse and the surrounding tissues, weakening them, creating a larger wound.
Okay.
Or taking your own bacteria from other places of your body if you're taking a bath and getting it into that open sore.
Got it. Fascinating. Okay, very good. This has been awesome. Thank you so much. So if someone were to, because I know you recommend early treatment, like if you're starting to see anything that is trending the wrong way, it's not healing like it should be, to contact a wound care specialist. If someone wanted to contact you, what's the best way?
Sure, drwishnew.com.
Easy. And there's a contact us form there.
Yeah.
And then Marina for lymphedema care / wound care.
Yeah. ultratherapysolutions.com.
Very good. Thank you all so much for coming. This has been great.
This was wonderful. I enjoyed it.
Thank you for having us.
Awesome.
Good.